patient's stable. If they need Artline, they're probably not real stable. So most of the time I put in Artline. It's nice when they're in anticipation that they'll be having surgery or needing type blood pressure control. But a lot of times it's a little more frantic. It's like they're trauma patients that don't have a blood pressure. They're like, oh, the blood pressure cuff's not working. Well, that's because they don't have a blood pressure. So they keep cycling the blood pressure over and over again. So Artline makes it so that you can sense the pulsatile pressure. It can also give you an idea of their fluid status because of the changes in the waveform when they breathe. They're on mechanical ventilation. You can learn a lot. So it's one of my favorite monitors because you can run gases, you can draw labs, you can do a lot of things with it. But kind of tricky to put in. But things that you need to know are, maybe we should make this more practical. How do we do it?
Oh, well, just, if we're coming to set the line, you go to me. I need an Artline. So I do it when I grab the card. And then.
Right. So we
and
grab
then
the card.
Yeah, usually we have these guys in here. They'll start presentations.
LR or normal saline?
These are normal saline.
Normal saline is what you want to go through, only normal saline, nothing goes through an Artline, no medications, nothing like that, so normal saline is what you want. So eventually here, so bad. These new,
She's gonna pressurize that.
the only thing is that I hate are new bags, they're like the 1,000cc bags, you can still use them, but they're not, they're kind of harder than.
When you tear open the tubing, I just give you a warning that you want to keep track of these. Sometimes pop open the loop and get lost. This tubing is not regular IV tubing. It's stiffer, and if you notice, like if you feel the tubing, on one side it's squishy like IV tubing, and that's the side that you're gonna plug into the fluid, and then the side that's the patient, it wants to feel the pressure without losing the strength of their pulse, so it makes the tubing really stiff and hard. So sometimes if this is a mess of tubing, and I want to know which side the patient is on, which side the blood is going to be on, it's going to be on the stiff side. So how would you prime that fluid? Prime this line.
Make sure that it's closed, that's closed. Hook it up like normal.
Okay.
She's
Why don't you do it?
Oh, I think she's recording, Dr.
I
Asper.
can record it.
Your face isn't being showed.
That's why.
You're too tall.
We just see you from here.
One of those
Was that right?
real important things on the Artline, though, correct me if I'm wrong on that, is you don't want any bubbles at all.
But here's the thing, making it practical, I want to put somebody who hasn't done it, let them find the
Here, I got it. I'll do it.
things that they're gonna fail at, so that
This is
they
gonna
can
be
learn
my
from
job.
it and then not fail when they
You want to push the air
do
there.
I'm gonna fail. It's fine.
That's all right.
It's okay.
So I learn the best when I fail. So it's
We're all
good.
friends here.
Now I'm gonna be super sweaty after this, you guys.
So that
Oh, I
we
need
need
to-
to have pressurized. So
Dr. Asper's already gone through this with me.
It's just like a holder, just to keep it for that little.
Yeah, but if we're being honest, I don't know how to pressure it. Just pump it.
And the other side.
Oh, nice.
So you can see. And is that gonna stay in there?
so
So you gotta
This way.
And this way.
Oh, so it stays where you have to put
So then when you want to maintain,
So let's look on
start
this side
by-
here.
making sure your bag isn't going to fall out.
They're also gonna put
This
tubes at the bottom.
can slide through here
Oh, so you just
so that it keeps this bag
okay.
up.
And then you
Another
can open that.
another way that you can hold this in, like if the bag is short, pressure will hold this in. When you put enough pressure, it'll squeeze it
Okay.
against that, so it stays.
He's way over there.
Keep pumping. Keep going.
How do you know when to stop?
There's a lot of pressure. This is a pressure gauge,
Okay.
and it goes through different levels. Should show that. Keep going, keep going.
It's giving me a hand cramp.
Yeah, it's
Oh, there we go.
hard, you gotta get up to the green.
Oh, get up to the
So,
green.
so there's enough pressure in there.
So then you can maintain pressure. There, perfect. Okay.
Some of these can be loose, so I usually try to check the connections, make sure they're all tight. So this line is full of air. I have to get all the air out. So who's good at getting air out? Who's bad at getting air out? I'm just kidding. Do you want to flush that line?
You just pull on that blue thing, is that what?
So these tubings are a little different. You see that blue right here?
Mm-hmm.
Some of them will have, these all will be the pull. They're kind of a pain in the butt. But you pull, some of them have like a squeeze adapter, but these ones are you pull the string.
Point that at somebody.
I did it naturally.
Yeah, you want to get wet.
You're such a great teacher. It just, I could feel it.
Anyway, she pulls the string and then you shoot.
Right? So
There's bubbles in there.
what do you think of this?
Yeah. This is like
I don't like
completely
it.
gone.
Yeah.
Yeah, so
I'm
so
sorry. You gave me it out. I think it's pressurized.
so picture if you send a bubble into someone's artery, then it's gonna go along and get wedged and stop blood flow to something distal. So we want to get all the bubbles out. So as far as tubing goes, there's certain places where bubbles like to get stuck. I usually irritate the tubing, and these are small bubbles, but you can see that the bubbles will float up to the top. And there are certain places where bubbles tend to hide at the junctions. So you can see there's probably a good one with there. So sometimes it takes, yeah. Usually I have that sitting somewhere somebody won't be at. But sometimes you have to flush it through, and I'll tap the tubing on something to try to agitate the bubbles so they'll make their way out, and so that our line is all primed. If somebody's not familiar with art lines, they might mistake these for injection ports. You don't want to inject stuff arterially. Medications can cause vasospasm. It causes problems.
Can we switch them out for these ones?
Right. When these are when they were processed, these caps have holes in them so that air passes through. So you can switch them out.
After you put the caps on before you flush the fluid, or does it matter?
I don't know. What do you think? Does it matter?
If it's valved off, it shouldn't matter, right? So
I usually do that. I would get everything set
you
up.
want them all valved off.
Because you have it closed off there.
I don't, I have it
Not right
open.
now, it's
I
open.
never close it.
You
Well,
know,
if you have
okay.
the
So
air
it
bubbles, would
flushed
it be
through.
easier to go out with the one with the hole in it?
But what, yeah, does it allow the air to release as you're,
So where we flushed, no, these caps were, that part of the line was not connected to where we flushed. The flush
Okay.
went through here,
Great.
through there, right? So I guess technically, yeah, so we didn't use that, those ports. There's still air in there. And if we're using those, we're going to be drawing out. So we'll draw the air that's in between the warlock and the patient. We're drawing it out.
When you opened this tubing, it was already closed off there, or you had to close them?
This tubing had, all I did was replace the cap.
Okay.
So it was just like this. The line was open, but these are valves.
Okay.
So you can turn it off, and that becomes important when. So we have the tubing, it's primed. Then we have to hook up this transducer. This is going to be what measures the pressure. It's relative pressure. So so it has this handy little
Yeah, oh, it's-
connector that we have to hook up to the machines. Some of the machines, they should automatically populate a pressure. So do you want to plug this
Yeah,
in
I do
to a
wanna plug
machine?
So
See
this
if we can
one,
get this to read a pressure.
so I need this part right here, hooks up to the machine.
so you need the one that says press on it, because if you go in the ORs, in that middle drawer in the anesthesia machine, there's gonna be a couple of those. One's like orange, it says temp on it, and then there's a red one that's got pressure, so you gotta make sure you have the right pressure one.
It
The
should
temp says-
automatically, I haven't
Yeah, it's
played
got
with
like a little
this,
thing
so
on
it
it.
should,
Says
oh, there it
pressure.
goes.
There's an orange colored one, it says temp.
So that's not.
No, you don't want a temperature probe.
Let me see
Your
this.
art line just-
And this probe, I mean, this line will always be in here. Should be, I always check. So when you plug it in, you see this automatically comes up, art line.
Okay.
Okay, you just plug it in right here. All of them are the same.
So so here's the thing. I'm just testing to see if it matters which one you plug it into.
That's what I was
Right?
gonna ask you, if it did.
It pulls this one up as a CVP. It's the pressure number two, IP2. This is IP1.
Okay.
So this is reading this transducer, right? There's fluid in here. So if I jiggle this fluid around, it's going to read the pressure that it feels. So it's a rough check to see if things are working. If I wiggle this and I see a tracing up there, because I had the last one I put in, I put the catheter in, but it wasn't. But I looked on the monitor and it was a flat line. It's either that I'm not in, so the patient's not giving me a pulse. But I just went to the transducer and I gave it a jiggle, so I knew that this transducer is reading pressure. So that lets me know that it is measuring pressure. However, it's a relative pressure. Like if you put it higher, it's a different pressure than if you put it lower. If it's
So do you wanna keep it at that heart level?
That's what we have.
yeah. So I'm not this. It's tough in the OR situation where things are always moving around. You try to keep it at their heart level.
You're gonna use that.
But you
So
mount
just
these
sit
on poles, or
I wanna see that.
in the short term, you just set it by the patient.
Yeah, so say you set it on the bar.
Sometimes if, really, I'm concerned about cerebral perfusion, so I'll put it ear level. So, because my patient's mostly laying down, so their ear is close to their heart. So that's the line, and that is set up for that. Getting it flushed.
Are there?
Because I'm around people that haven't used these a lot, sometimes I'll tape these close. So they don't get used accidentally to put medicine in. And these connections, I always check because if I plug this into a patient and I have arterial pressure, that arterial pressure is going to push through here if there's a disconnect, and then blood comes spurting out. So
Do you
on
still need to do the 0
Yeah,
on
that's
the
why I was
monitor?
gonna wait for him.
Okay.
Yeah.
I know, that's one of the things, you're putting at the level, don't you just have to do the little bit 0 button and pull the button thing?
Well, what's that going to do if we use 0? It doesn't have the complete circuit
No,
yet.
okay.
No, but I just wanted to
But-
make sure that
But
we
you could,
discussed it.
I guess technically you could 0 this.
I got a syringe, I could plug it in.
I usually do it
After the
after
patient?
I'm
Okay.
hooked up to the patient, because then I know, yeah, where the patient is,
Okay, then you're.
where they're going to be. And,
Sorry, for some reason I was thinking it needed to be 0 before you guys put it.
Okay,
Roger.
Once you plug it into the patient, then you zero it. I haven't
Yeah.
played with the zeroing on this. Will you turn the valve off to the patient? And then I'll let him.
So are these ports then, from your experience, used to hook up to like another redundant type of monitor? Or is that just maybe for them in manufacturing for the sake of sterilizing it?
You can draw
Because they don't really
gases
use
from it. Is that what you
that's
said?
just for me, the lines, but that one's specific, I don't,
these caps,
because it's right.
really, this is a new cap, and I don't quite understand
Yeah, I've
why they
never
have
seen
that
where the
Warlock
valve is right where the turn
on the backside.
valve is.
Because
This tube
I've had
has
ones
it.
that look exactly like the caps that came off, but they're closed. But this doesn't open, it doesn't have a hole, so I don't understand the role of the
Yeah.
Because
Warlock on
if
the
you were to
outside.
take that off, well, yeah, of course you want to have the valve
'Cause you
off,
can't-
because otherwise.
Well, when you can see that,
Pull anything right
I
there.
see it
Pulsing out.
as a cap on the, what would that be? You can cap both ways, I guess.
Oh, thank you.
Right, the cap works this way
Well, maybe that is just
And
for
it
their
works
sterilizing.
this way
It's off
as well.
when it's sterilized.
Yeah. So it caps male or female, multi-purpose cap. But that's where the cap goes. So to zero it, here's the most common problem I see when people go to zero it. I'll be hooking up the patient and securing the arterial line, and they'll go to zero it, and then all of a sudden blood comes shooting out because this is hooked to the patient, so arterial pressure and it's pushing back this way.
They don't close them.
So which way would you open this so that you don't get blood shooting
Shoot
back
out
at
of
you?
there. You want it
Here's your take your guess.
This is the patient.
Which way are you going to turn that valve?
Yeah,
Okay. And why did you pick that way?
because it stops it, closes out the gateway.
But there's pressure on this side and pressure on that side.
This side is to the monitor,
Okay. How do you know?
because it's the squishy.
Okay. Okay. Because it's kind of, yeah. So what you do is you turn the valve so that the transducer reads the ambient pressure, air pressure. So turn it open to air is what they'll say. Okay, and what would happen if you do that? That's when you get blood shooting back out at you. So
Can it go?
what's that?
Can it go down?
Down where?
This go.
No. Yeah, you got those two options. So it's
Cut your air out, put your transducer.
So this shuts the transducer off, but then opens it up so that the arterial pressure pushes
so
back
will you
out.
change that one? If you don't want blood shooting out, when you want to zero it?
So
So it points to off, correct?
yeah, this is off that direction. So for patients on that side, you shut the pressure of the patient off. The air pressure then can go into the transducer, so it measures the air pressure. So this is the position that you want to do when you zero.
Do you hit it and then zero? I haven't played
So
with this.
there should be a
There's a zero right there.
Oh, thanks. I can't see even
So
with
you
my
tap zero,
tap
and
zero.
it'll
And then it usually will do a zero.
zeroing, and
Yep.
see how it brought that line down?
To zero.
It did a little step off
Under, yeah.
because
Right. So then it's zero once you get that.
then once that's done, then you can turn this so that
You get the pressure back from
it's
the patient.
off, and then it'll start reading the pressure on this end.
Oh.
But again, aren't we gonna have a cap?
That blood
that's
pressure's
measured
not
on there?
Yes.
I mean, it's not
That's the
using
thing.
this port to allow the air
So-
pressure to
so
the
technically-
transducer?
When I'm doing this, the old caps are on there, and they open to air, and then I replace those caps once I've zeroed it.
Yeah, and they have little caps that they replace them with.
So I guess
There's those
in the
that come
demonstration,
there.
when I started, I put these on,
So then I replace them with those.
but
Because those ones have.
with this cap on there, with that cap on there, it still opens to air.
So if you
So
pull
you
that,
can-
you could spray water out there, right? Or no?
That's what I'm curious about, is it's like, this is just fluid, or is it air and fluid through that port?
Yeah, this is open. So,
Do you want me to pull it and just, it'll, like, what you're looking for, Roger? Like, you gotta man.
sometimes I learn that way.
Yeah, look, see?
yeah, you can flush through that. So I guess to backtrack, don't worry about replacing this because you can zero with that on, and then once it's zeroed, you can take it off with the cap, so that then it's not an infectious
Yeah.
route because it doesn't have possible
Yeah, we don't have
contaminants
those little
going.
CHG caps or locks.
All right. Anyway, that's my trick on how to tell which side the blood is going to come squirting from.
Get your mind out of the gutter, kid.
Turn it off to the patient. Make sure that there's either a cap that breathes, or you can take the cap off and read the pressure of the air. Zero it,
Cap
and
has
then-
to be a breathable cap.
and then once it's zeroed, you can turn it so that it'll read the patient's pressure. There are times, there's a lot of, sometimes you have to flush arterial lines because they'll have, because the end catheter caught on. But you can usually see that as the tracing starts to dampen. And then you question if the patient's pressure is dampening, going down, or if it's just monitor error.
So we wouldn't want these bubbles, right? So could you pull them out like you do the
That's what I was wondering on
tubing?
these ports here too, if you,
Just
So-
with a syringe, just pull out the bubbles?
Right, you don't want to send those to the patient, so you could hook up here.
Mm-hmm.
You can flush through this port, right?
Yeah.
This is so clear, but you can be able to pull this, and it flushes
Okay.
from the pressure head that you created from the pressure. Now, when this is hooked to a patient, you can flush it and you can use this pressure wave, but
It's not happy with it.
let the doctor do it. Because here's the other thing. They've done radiographic studies that the pressure that you shoot through this can go quite a ways without flush. And so
So when you're looking at the art line on a patient, then where would the blood, you're obviously measuring the blood pressure in that artery there. Where should you, I would think you wouldn't want to see blood in this line, because then there's a chance that you'd be getting, coagulating or something.
Yeah,
And
I mean,
ideally,
it's
it's
like an
probably
IV.
somewhere right.
when you have an IV, you see that blood in there, and you know that it's limiting the flow, dampening the pressure, clotting. You don't want to have stale blood in there. It's clotting up, because where are those clots going to go when that line gets flushed? They're going to go arterial. They're going to embolize, and you have to switch your brain. It's not venous.
Yeah.
It's not going to go to the lungs and naturally filtered out. It's going to be delivered to the tissues and have an effect. So the clots you'll get petechial, thrombi distally, which I'm trying to avoid.
So IV fluid, that bag, okay, so it's hooked up and you've got.
So we're just
zero.
using it for the pressure.
It's
It's
just
not-
for the pressure, it's not something that's
Yeah.
consumable that you're
'Cause-
floating in there.
Because right now we're reading the pressure. Well,
You can't
That way.
flush it with that
I
though.
took it off
It's
because
not, so,
right. So this is reading the pressure, even though it's just using that column of fluid that's not compressible. That's another point. If there are air bubbles in there, air is easily compressible, so it'll dampen your reading. So it makes it so it's less accurate.
Sluggish
Because it was-
looking chunk.
So they talk about blood flow, right? Arterial line is going to go most of the time. We're looking. I'm looking at a radial artery, but you can put it in other arteries. Femoral artery. I've seen those in the ER. They're concerned about if you plug up the radial artery, you want to make sure that the patient has good flow of their hand through their ulnar artery. So they talk about Allen test. Just to be complete, I'll kind of touch on that briefly. But can anybody feel your pulse on the ulnar side?
it's a little harder.
If you can't feel yours, I'll show you mine.
I want to sell yours.
It's funny because you never tried it. I can't feel
The Allen test is basically you try to occlude both arterial flow to your hand, right? You can open up your hand and then you do radial, ulnar
Mine works.
flow, and you see that the
Is that how you pick, decide which one you're gonna use? Do you do the Allen test? Or do
I go
you just go?
I
with
check to make sure they have
Good
a
radial.
pulse.
Yeah,
Yeah.
pulse is good.
I'm going for radial.
Okay, all right, I just was curious if you
Monitor
checked.
it from
to see-
there.
Yeah.
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 But that's the Allen test, and they say you can use Doppler to check flow. What I think is really handy in the ER is they usually have an ultrasound. Ultrasound placement is great. I can see how pulsatile, how big the artery is, and kind of check the flow there. When I place a radial art line, I like using. They're different arterial line kits. This is what I like. Aero radial artery catheterization set, because it basically has most of what I need right here. And as far as sterile technique, trying to place it sterilely. I do sterile prep at the site. If I have an ultrasound in an emergent situation, I use an ultrasound that's not sterile, but I try to keep it above my sterile field. And my sterile field is right where I'm going with this arterial catheter. I'll open one of these to kind of show you what I face. This does have a sheath on it, so if my hands are full with this, that, and the other, I may have you pull that off. I'm going to try to keep the angiocath on there, so pinch that. The sheath comes off, and then it's basically just your IV catheter kind of thing, right? However, this this catheter is pretty fragile. The end of it will catch on the skin and peel back and leave kind of a roughened edge that I don't want dragging through the artery. So sometimes I'll ask for something sharp. 18 gauge needle is nice, a nice cutting needle, so I can poke a hole in their skin, so that when this slides through their skin, it doesn't burr the edge, the front edge of it, because then it's hard to get into the artery. Because if it burrs at the skin, then imagine trying to get through something more sensitive like the artery, the vessel. You'll poke through, and then it'll just tear the lining of the artery. And speaking of which, it'll make a big bruise. Like, it'll swell up arterial. It's not just, you see some big venous bruises. Well, arterial, it'll start bubbling up pretty big when the artery splits. Other things that the artery does is it'll vasospasm. So sometimes by injecting local anesthetic lidocaine around there, it'll dampen down the nerves that control the vascular muscle, so that it will vasodilate a little bit, so make the artery a little bigger, and just like lead the spasm. Process this. I try to position the patient so that I can get into the radial artery right as it kind of rounds that bony part where you're checking the pulse. So I usually have to have their hand extended a little bit. Sometimes I'll just roll a blue towel. Sometimes I'll tape the thumb, something to keep them in the wrist in an extended position, so that I can get this as flat as I can to get in the artery. And then if you're watching me do this, I'll just talk you through the process. I go until I see a flash of blood. I'm hoping that if they're well oxygenated, it's going to be bright red as opposed to a darker venous color. And usually it has a fair amount of pressure behind it, so it'll shoot back into this, and it'll start filling this up. So there is I think there's something that keeps it from pouring out the end, but I'll get into the artery. I'll try to flatten so that I can slide the tip of the catheter into the blood vessel a little bit more. And the nice thing about this is you can do Seldinger technique, right? This has a little wire. This wire slides through and comes out into the artery, right? So it makes it so that if I can get this to slide, it even has a line showing me that if I get to there, that's going to be the tip of the catheter. If I can get it to slide past there smoothly and easily, it's hopefully sliding right into the artery. And then I can slide this catheter over the top of that wire, and it'll be inside the artery.
You'll see them in there holding it, and then they're playing with that little black piece. And they kind of adjust, and they'll like try to slide it a little more, and so they're playing with their little guide wire.
But if you watch me do this on a patient, is a moment of truth where I'm trying to hold to prevent arterial blood flow from spraying out of this catheter with this finger, and I want to have the end of this ready to go so that I can just grab this and twist it on there. So that when this comes out, arterial pressure, I also try to make sure,
No one's standing there.
Or you're
right,
holding
arterial
down
pressure is
so-
gonna squirt blood out if I slide off the artery. It'll be a good indicator that I'm in, but you also have to plan that you could have blood all over, so make sure you have your PPE and your, if you have some type of but anyway, and sometimes if this gets to be kind of a bloody situation, it can be hard. This can be slick. It's easy if you've ever had a IV disconnect. You have a venous blood spilling back, especially if you have a tourniquet still on. Well, picture arterial blood. It's going to be squirting out, and it's more likely to kick this off if it's not a tight fit, because there's more pressure there. With that in the patient, then we want to secure this. They have little holes to secure with suture. Usually, I like to throw a tegaderm on first, and then go from there to secure the rest of it. Coban, yeah. So that as the patient moves around, this doesn't move around. You have to watch out because picture seeing a patient like this. Then
That's
you
my
have
next question. You don't do like how we do for catheters. You guys usually have it like straighter, right? You don't want to like loop it up.
well, I will usually I do some
Curling
type of
back?
a curling back,
Okay. I didn't know if there
Um,
was anything with the
but you have to watch out. This needs to be padded, or need to make sure that it's not in a place that can cause injury from.
Make sure it's not pushing on the artery, impeding you.
So, what else do we need to cover?
Well, good compression bandage on it if you had to go to the other side, right?
Right.
I mean,
Yeah,
if you got in and for some reason you couldn't thread that one, then just heavy amounts.
yeah, pressure dressing with.
Because if that's under the drapes, you don't
More
want to come back
pressure.
later and.
But yeah, you don't want to tourniquet their hand, but you want to have, put a folded